So this, for those of you who have worked with me extensively, a lot of these concepts are going to be review. But I wanted to do a little bit of a kind of sleep surgery introductory lecture this morning. I know we have a couple of other awesome speakers coming up in the next couple of months. Denise is going to speak about the upper airway, and then Tucker Woodson, who is largely known as the grandfather of sleep surgery, or the father, I guess I shouldn't say grandfather, father of sleep surgery still at this point. He will be speaking to us as well. So I'm really looking forward to those talks. But this morning, I just wanted to hopefully kind of offer a perspective of a sleep trained ENT and how I approach the obstructive sleep apnea patient. I think it's still a relatively small group of us who are dually trained in both sleep medicine and ENT. And I think there are some central concepts that we all share when we're approaching these patients. So the most common person that lands in my clinic is someone with this complaint. You know, they know they have sleep apnea, but they can't wear their CPAP or their CPAC, as they often refer to it as. So what do we do with this person? So these are going to be some, ends of the spectrum, but this is the typical view of CPAP from someone who may not really be familiar with using CPAP or treating patients with CPAP. You know, it's this awful, terrible mask that just kind of overwhelms the patient and interferes with their life. So if you talk to you probably run-of-the-mill sleep surgeon who may not be as familiar with CPAP, this is kind of what they're thinking the patient's dealing with. They hate it. So, surgeon, I've got some nails, I've got a hammer, and well, there's this thing at the back of the throat, that palate, it's got to be in the way. So why don't we just cut it out? Happy surgeon, happy life. Now, on the other side of the coin, this is there a question, comment? I just heard something real quick there. On the other side of the coin is the, general sleep medicine perspective of sleep surgery. And when they see these patients, there's a different perspective here. So there's this paper in the literature. It was a survey of sleep medicine physicians. It's in the dental literature on their perceptions of surgical treatment of OSA. And the poll basically said, what are effective surgeries for sleep apnea? And I was struck by a couple of things here. One, the answer choices. So from my perspective, there are a lot of things missing here. Some very viable solutions for patients that are missing as answer choices. And the other thing that struck me is basically MMA or bust is kind of the viewpoint here with sleep surgery. And I thought, oh gosh, this is probably a really outdated study. It's from 2017. So this is the perspective about 3 or 4 years ago of sleep surgery. And then additionally, this is something that is actively going on. I'm on the sleep committee for the Academy of Otolaryngology, and there's currently a draft of the US Preventative Task Force on obstructive sleep apnea. And in the treatment section, the only things that are mentioned are positive airway pressure and oral appliances. So this group has been pinged to talk about the literature behind effective sleep surgery. There's no mention of surgery in this section, and this is something that's actively ongoing right now. So, from the general sleep medicine perspective, you got to get back on the CPAP. Really nothing else to do here. So there's got to be some happy medium, and this is why I chose to do what I do and treat the patients I treat. So I wanted to use the rest of the time to just talk about, when I see a patient coming in with this complaint, how do I try to balance the medicine and the surgical treatments and give them a reasonable option for treatment? So the first thing that I try to do in these patients is really back up and really explore what CPAP failure means before we just jumped to CPAP alternatives. The first question I will ask most of these patients when they're in my clinic is, think back to that first diagnostic sleep study you had. Why did your doctor order it for you? What led to treatment? What led to testing in the first place? And I will say most patients will say, well, I was struggling with my sleep. Okay, what does that mean? Some of them will give you a very a history with a high pretest probability for sleep apnea. They'll say they're snoring, they were gasping, their bed partner was elbowing them, they were stopping breathing in their sleep. But a lot of people will just tell you, I didn't have energy and my sleep just wasn't refreshing. And so, the first thing I like to do is try to unpack this. Were all these symptoms due to your sleep apnea in the first place? Or maybe are you struggling with your CPAP and are you struggling with symptom resolution because there's other stuff going on? And we all know that often the answer to that is yes. When we talk through a sleep history, we're finding that a lot of these patients are struggling to fall asleep. They have insomnia. They may have movement disorders like RLS. A lot of them are just not getting enough sleep. I'd say a majority of our patients are just not getting enough sleep. And then additionally, there's often other issues, non-sleep issues that are coming into play. They're on gabapentin 3 times a day. Okay, well, that's going to make them sleepy, or they have chronic pain issues, arthritis issues that are interrupting their sleep at night. So I think it's really important to pull this into their history and discuss some of these issues, as these are often why they're not getting full relief from their CPAP. Additionally, not to mention, it's important to look at a data download because sometimes they're just not on the right therapy for their obstructive sleep apnea. A question that I really like to ask patients to try to gauge whether or not their sleep disordered breathing is the cause of a lot of their symptoms is, on a good night, did you ever feel any benefit with your PAP therapy? On that magical night where the stars aligned and you were able to keep it on all night, did you feel better in the morning? And a lot of patients can, say, yeah, I think that one night that I was able to keep my CPAP on, I did feel a little better. It's just really hard for me to use it. And in that case, I feel more comfortable offering CPAP alternatives such as surgery for OSA, knowing, okay, maybe there is a chance here we can get some benefit just taking care of that obstruction. Other patients can really pinpoint for you specific areas where they had trouble. A mask fit problem where they had a leak into their eye, pressure intolerance. And so there are sometimes some things that we really can tweak and fix. We know in the literature, the biggest thing behind CPAP adherence is a lack of support and education through the process. And I'd say at least half, probably about 50% of my CPAP failure patients that are often coming in self-referral or PCP referral, they just don't know anything about, they never were told what their sleep studies show. They don't know why they're on the CPAP. They just basically had a home test and had a CPAP come from a DME and really didn't have support through that process. So I think that's a big key thing that we can help patients with too. There are some patients, when you ask that first question, what led to your sleep testing in the first place? They just say, I don't know, I didn't really have trouble with my sleep. My doctor just ordered it because my blood pressure was a little high. So there are some patients that were tested in the first place due to medical comorbidities that they may have. And I think it's really important, especially in this cohort, as we're talking about CPAP alternatives, including surgeries, to make sure that the risk of our treatment is not actually worse than the risk of the disease itself. So this is where I think it's really important to know, really break down the sleep study and know the disease process that you're treating, and also really know the body of literature on medical morbidity of sleep disordered breathing. So to know that generally it's really our based on what we know in the literature, it's our sleepy patients and our patients with a reasonable degree of nocturnal hypoxemia that may be at the most risk medically. And so we have to know this literature to be able to have these risk benefit discussions with these patients. So this is a nice place to just mention that the AHI is a moving target and probably not the best thing to pay attention to when we're comparing sleep studies and perhaps even discussing medical risk and medical morbidity with patients. So the AHI is honestly a pretty arbitrary thing and has changed throughout the years. An apnea has been scored the same since the 1960s, but the hypopnea is truly a moving target. And it's going to vary lab to lab. It's going to vary perhaps on home testing versus in-lab testing. In our world at UH, it varies based on the insurance a patient has. So, a patient with Medicare versus a patient with commercial insurance could have the exact same night of sleep. One might have mild apnea, and one might have moderate to severe apnea. So I think this is a really important thing to pay attention to. We know that the patients who are being scored based on the updated AASM rules, where we can score a hypopnea on a 3% DSAT or an arousal, these patients tend to be younger, less obese, they're more likely to be female. We may be identifying a different cohort of patients who can be quite symptomatic, but may not be at the same cardiovascular risk as those who might have come up with sleep apnea based on older scoring rules. So this is where I think it's really important to look at some other numbers on our sleep study reports, such as the oxygen nadir, the time the patient's spending below 90 or 88%. And a number that I always really like to look at too, because it's a bit more objective and consistent test to test, is the number of times per hour that the patient is desaturating by 4%. Another thing to discuss here, and I'm not going to go into a lot of detail on this, but we're learning that obstructive sleep apnea is probably not just one disease. It's going to be a cohort of different physiologic factors that lead to that patient's elevated AHI. So this is a really nice review by Eckert. He has a few papers in the literature that discuss OSA endotypes. We know that the key underpinning of obstructive sleep apnea is going to be some sort of compromised upper airway anatomy. It's either narrow or collapsible. But there are plenty of people who look like they should have a beautiful open airway at night who actually have bad sleep apnea. And then on the flip side, there are plenty of people who look like, man, they've got to have sleep apnea, and they don't. So there are other things that are involved here in the sleep disordered breathing physiology. So ineffective upper airway dilator muscles, when we go to sleep, that neuromuscular control can be more compromised in some than in others. The unstable ventilatory control system. Some people are more prone to overbreathing and underbreathing with very small changes in CO2 and O2. That can lead to an unstable state and more propensity for upper airway collapse. And then lastly, some people are going to arouse from a stable sleep state more easily than others. And that can potentiate this high loop gain situation where we're overbreathing and underbreathing. This review, they found in their physiology labs that about 28% of patients actually have multiple non-anatomic factors. And you can see over a third of patients had at least one of these other issues going on. So I think it's really important, especially as a surgeon who's considering operating on the upper airway and perhaps only taking care of one of these branch points, to consider, is this a patient that has multiple non-anatomic factors that also need to be taken into account? I saved this hypnogram because I thought it was a really nice representation of someone who probably has some non-anatomic factors going on. So as I recall, I think this was a middle-aged female patient who was symptomatic and did have, I believe it was a moderate sleep apnea case. But just looking at the hypnogram from this patient's night, something struck me. You typically think you're going to see that a patient's going to have their most profound events, most profound desaturations in REM. But what happened with this patient is, you can see this unstable section of sleep towards the end of the night where they're going back and forth from wake to N2 to N1 is actually where they had their most significant events and significant O2 desaturations. And then when the patient was able to achieve stable REM sleep towards the end of the night, and even a chunk of stable N2 sleep in the middle of the night, they actually did quite well. They didn't have many events and their O2 saturations were stable. So this is someone who may have moderate to severe sleep apnea, but when I look at their hypnogram, it strikes me that there probably are some non-anatomic factors affecting this patient as well.
Although, Amy, that could be position too. You don't have position.
Yes. So some of it was. Thank you, Denise. Some of it was position. They were, I would say, during the REM period, a lot of that was on their side. During that N2 period earlier in the night where they were stable, they were on their back. So I totally agree that position was part of this too, but I just, those transitions, I believe during that piece, the patient was also on their back. But yeah, so positional, and then I think there was some non-anatomic physiology going on here as well.
I think the other is, I was thinking about something that wore off, and maybe that's one of the antidepressants, shorter acting, that also affect respiratory control. So you increase loop gain towards the latter half of the night. But I that's just speculation.
Yeah, I mean, I think there's probably a lot of unknowns too, but it's just something.
There's no REM sleep in the right spot either. So yeah. Okay. Nice example.
No, just an example. So the rest of this talk is largely going to focus on what can we do in terms of CPAP alternatives and surgically. So most of that is going to fall into the categories that I have circled here. So we have strategies to improve the narrower collapsible airway. And then I think with hypoglossal neurostimulation, we're also talking about a therapy that can potentially address the upper airway dilator muscles. So what are our anatomic non-surgical treatment options? This is review for everyone on the call. CPAP is our upper airway pneumatic splint. The oral appliance potentially can adjust the position of the lower jaw and all of the soft tissue structures that are attached to it. And then there are several other behavioral modifications that can help a lot. We know about half to two-thirds, three-quarters of sleep apnea can be positional. So positional therapy can help. Upper airway exercises may become more in vogue with Dr. DeWalden business. We know that patients who play instruments like the oboe or the didgeridoo do better with their sleep apnea, and so that's something to consider. We know weight matters a lot. A 10% change in body weight can lead to a 25 to 33% change in AHI, so that's huge. And we know that patients who are able to quit smoking and cut down on alcohol use can also improve their obstructive sleep apnea. As far as surgical therapies, this slide is meant to be overwhelming. Sleep surgery is still the Wild West. Sleep overall sort of is still the Wild West, but sleep surgery definitely is. There was a review written about sleep surgery about 7 years ago now. And this is the list of procedures that they came up with that was in the literature. There were almost 30 of them. And just looking at the list, I can tell you there are a handful that are clearly missing to me. So there are even more options than this. Overwhelmingly, the types of sleep surgeries that are done are those on the palate. So when this was written, about 35,000 sleep surgeries were done per year in the US, and 33,000 of those were surgeries on the palate. I think with the advent of neurostim, that ratio is changing, though overwhelmingly sleep surgery is still done on the palate. But there are so many different procedures out there. And the things I'm going to focus on today are going to be the ones that I think are more commonly employed among those who are doing mostly sleep surgery. When I talk about the types of sleep surgery to patients and ENT residents when I'm teaching them in clinic, to make it a little bit more digestible, because that list is pretty overwhelming, I like to refer to the surgical treatment options as 4 different buckets of surgical treatment options. So the first bucket is not a surgery that is meant to get a patient off of their CPAP, but a surgery meant to help them with their CPAP. So a surgery to improve medical treatment efficacy and adherence. The second bucket is going to be the soft tissue surgery. So surgeries on the structures inside the throat to try to make that airway more open or less collapsible. Bucket number 3 is going to be bony surgery. And then bucket number 4, upper airway or hypoglossal neurostimulation. There are multiple factors that go into choosing what is going to be the best option for each individual patient. What does their upper airway anatomy look like? What is their BMI? How do they carry their weight? What is their age? Do they have other medical comorbidities that would preclude them from undergoing a jaw surgery, for instance? Are there other medical or psychiatric or sleep comorbidities that may make it difficult for them to tolerate something such as their tongue moving all night long? And then lastly, I always try to at least think about that physiology. Are there other underpinnings to their sleep apnea that may make it a little bit more difficult to control them with an anatomic solution? So surgery, it all started with the advent of the UP3 in the early 80s. And this always strikes me, it's the fact that we really haven't been treating sleep apnea for very long. Cpap really came to be in the late 70s, the UP3 in the early 80s. But pretty much surgery back at that time, aside from a trach, was this one size fits all uvulopalato-pharyngoplasty, which basically involved removing the tonsils, removing the distal palate and the uvula, and suturing the tonsillar pillars together. Immediately postoperatively, looks great. Unfortunately, for a lot of patients, that didn't pan out and it was not successful. For some, it's because this kind of circumferential scarring pattern can actually narrow that velopharyngeal port. But overall, the success rates initially were reported at less than a flip of a coin, so about 40% for the uvulopalato-pharyngoplasty. And this led to discussion of phenotyping. So how do we figure out who that 40% is? How do we know which patients we can help with a UP3 and which ones are going to do poorly? There are different ways to do this. So the first thing listed here is the AHI. So it's thought that a patient that may have a lower AHI may only have single level collapse at the level of that palate. Those with more severe sleep apnea probably have multi-level collapse at the palate, base of tongue. So perhaps that's someone that you can't help as easily with a palatal surgery. Something else that many on this call I'm sure have heard of is Friedman staging. So this Dr. Friedman put together a staging system which uses tonsillar size and also the Friedman palate position, which is it's very similar to the Mallampati, and looks at both of those things along with the patient's BMI to try to parse out who's going to do well with a UP3 and who's not. So the Friedman stage 1 patients are basically the ones with a small tongue and big tonsils, and they're not morbidly obese. And unsurprisingly, these are the ones that can do well with a UP3. Those who have large tongue and large tonsils, or a small tongue and small tonsils, it's basically a flip of a coin. So those patients, it's 50-50 whether or not they could achieve success with the UP3. Stage 3 are those with that really large tongue and they don't have tonsils or they're small tonsils, less than 10% success. And then also anyone with a BMI of over 40 also fit into this category where the success rate was less than 10%. There are maneuvers that can be done awake in the clinic to try to get an idea of what the patient's airway looks like when they're asleep. You can lay them back in a supine position in the exam chair. You can have them try to simulate their snoring and see which structures are collapsing and fluttering. And then lastly, the Mueller's maneuver, which is an inspiration against a closed glottis to try to create a negative pressure in the upper airway. That is something else that the patient can do awake so that you can have a view of what might be happening at night. Different imaging modalities can be used. So in the orthodontic and oral surgery world, cephalometry and CT, cone beam CT are often used. MRI can be used. In the ENT world, the most common airway phenotyping exam currently is the drug-induced sleep endoscopy, or the DICE. So what that is it's basically exactly what it sounds like. It was first described in the early 90s, again, to try to figure out who was going to do well with a UP3 and who was going to struggle. But basically, these patients are sedated in the adult population, mostly with propofol, and the pediatric population, mostly with Dex, Precedex. And they're basically kept on their stretcher. They're rolled back to either a procedure suite or an operating room, and then they're given this kind of low, slow infusion of propofol to the point where they're just falling asleep. And we look in the upper airway to see what happens. This is not natural sleep. There are a few different ways we try to figure out whether or not the patient's at the appropriate level of sedation. We try to obviously pay attention to signs and symptoms of sleep disordered breathing. So just as the patient's starting to snore, you can note some paradoxical breathing. They're no longer responding to voice commands, but are not at a point where they need extra support with a jaw thrust for their airway. The other thing that we use, you can see in this picture here, there's some stickers on this patient's forehead. That's a BIS monitor, or bispectral index, that's typically used on paralyzed patients to determine how deep of sedation they are in. But there's some literature in the anesthesiology world that suggests when the BIS is at a level of 50 to 70, that's where that genioglossus tone is just starting to drop off. So that it's just another data point that can help us determine whether or not the patient's at the appropriate level of sedation. During these drug-induced sleep endoscopies, you can vary the patient's position. You can do them with an oral appliance in and out. I will always, even if they don't have an appliance, manipulate the jaw to try to see what an appliance might do for the airway. You can also scope through a CPAP mask and see what's going on. It's a little bit harder to do with the nasal masks, but with the full face masks, you can use these bronchoscopy adapters and actually insert the scope through the mask into the airway. This patient on the right in particular was someone who was really struggling with elevated pressures and elevated AHI with her CPAP, and she really liked using her full face mask. But what you can see happens is underneath her mask, her mouth opens, and the delivery of positive pressure through the oral airway was serving to push her palate and tongue backwards, thus requiring higher pressures to open that airway. And all we did in that second picture was just with one finger close her mouth, put her in occlusion, and her airway opened up beautifully. So this was someone we talked about. Can you add a chin strap to that full face mask? Do you get an oral appliance simply to stabilize that jaw and keep you in occlusion? But we used a dice here to help troubleshoot her CPAP. It wasn't necessarily to look for surgical solutions. So this is a tool that can be helpful.
So Amy, is the type of mask that you use to deliver anesthesia, or at least, I guess this doesn't deliver anesthesia, this just allows you to manipulate.
No, this is all IV anesthesia. So it's all
Right.
It's all propofol by vein. We don't, sometimes they'll want an oxygen cannula kind of hanging out by their nose, but
Right.
other than that, we try to keep the face clear of anything so that, you know, we can use the scope. So this was just in the second, she brought in her CPAP machine from home.
Yep.
And had it on as we started the propofol drip.
Yeah, that would be interesting to kind of put it on and then drop the pressure and see what happens too. But I think your point that she has a full face mask and the jaw falls back is a good one. Thanks.
That's why I hate full face masks. But so I want to now go through these different surgical buckets. So bucket number one is going to be the surgery that is meant to, or medical therapy that is meant to help the patient use their CPAP or their oral appliance, for instance. So the general teaching in the literature is that nasal surgery does not reduce AHI. I have a little question mark here because I think most of these studies were done with older scoring rules where hypopneas were scored based on a desaturation and not necessarily an arousal. I hypothesize that potentially if we're looking at those arousal-based events, we may be able to mitigate some of those with opening up the nose, but I don't know that for sure. What we do know, and is pretty consistent in the literature, is that in patients who tell you they do have symptomatic subjective nasal obstruction, as well as an objective finding on exam, nasal surgery or medical treatment to open up the nose can improve snoring, sleep architecture, sleep quality, Epworth scores, and it can help with both oral appliance and Cpap adherence. So different things that can be done here. Medically, we very often use steroid, antihistamine sprays, saline irrigations that can help with largely turbinate hypertrophy. So those kind of sausage-like structures that sit on the lateral walls of the nose basically have erectile tissue that can be reduced surgically, reduced with topical medications, and also reduced simply with gravity. So you have a lot of patients tell you that they feel congested when they lay down at night, or the side that's down on the pillow gets more congested. That's simply gravity pulling more blood flow into those turbinates. The septum, which is the wall that separates the two nostrils, can also be deviated, and in patients who you have subjective daytime nasal obstruction, it's reasonable to consider opening up this nose medically and surgically to help them out.
Hey, Amy,
moving on, yeah.
How about the resistance at the entry of the nose, like with regards to, so like the nasal alae, if that's an important target and not just the turbinates and the septum?
Yeah, so for most people, the area of highest resistance in the nose is the internal nasal valve. And that's the area where the inferior turbinate and the septum make its most acute angle, normally about 10 to 15 degrees. But there are patients, if you examine them, some patients do have external nasal valve collapse. So the external nasal valve is that opening at the ala. That can be improved surgically. It can also be improved with things such as nasal cones. The nasal dilator strips are more for the internal nasal valve, but the nasal cones and nasal pillows masks, for instance, can actually serve to help stent that external nasal valve as well. So I think for it depends on the patient and their exam, but overwhelmingly, most commonly, the area where most resistance is going to be experienced is the area that can be narrowed due to the inferior turbinate and the septum.
Thanks.
Did that answer your question?
Yep, thank you.
Bucket number 2. So this is the soft tissue surgery. So the surgery on the floppy bits inside the airway. Overwhelmingly, like we said before, these surgeries are going to be on the soft palate area. And over the past decade, 15 years, there's been a very significant paradigm shift, at least among those who do mostly sleep surgery, to reconstructive UP3 techniques rather than destructive UP3 techniques. So before, it was pretty much just removing all of that tissue. Now it's more of a rearrangement of tissue. So these are a couple of examples of palatoplasty techniques. I would not be surprised if this is something that Dr. Woodson goes into detail on. He actually has written a body of the literature on palatal surgery. But for instance, when we look in a patient's airway and we see, okay, at the level of the palate, what's going on? Different patients have very different patterns of collapse at the levels of their airway. So what you're looking at on the left side of the screen here is a dice view looking at the roof of the mouth from above. On the bottom of the screen is the palate from above. The top of the screen is the posterior pharyngeal wall. And then when you're looking at on the side walls, is what we call the lateral walls. So that's like that salpingopharyngeus muscle heading down into the palatopharyngeus muscle. Those are what we call lateral walls when we're looking in the airway. So the patient on the top doesn't have a lot of lateral wall tissue. They have more AP or front to back collapse. The patient on the bottom, those are some chunky bratwursts, as Dr. Woodson likes to call them. So perhaps the patient on top, you're going to consider a palatoplasty technique that tries to open up the patient in the AP direction. On the bottom, you're going to try to consider something that's going to open up laterally and pull those lateral walls out of the way. The technique on the top, the TPA, is Transpalatal Advancement. This is used, I would say, pretty infrequently at this point, largely due to outcome of palatal fistula in some of these patients. But basically what's done here is there's an osteotomy made in the hard palate, and then that the posterior portion of the hard palate is brought forward, thus trying to open the patients up in the AP dimension. On the bottom is this, it's called the expansion sphincter Pharyngoplasty. It's basically the opposite of the operation done in cleft patients to restore competence at this level. And what's done here is the palatopharyngeus muscle, which is located behind the tonsil, is isolated and moved laterally and superiorly. There are a lot of different versions of this operation now, but the general goal is the same, and it's to get that body of muscle in the superolateral direction. What we've learned now is that this expansion actually in the patients with the right palatal anatomy can open up pretty nicely in the AP direction as well. So something that you'll hear Dr. Woodson talk about a lot are his various palatal phenotypes. There's the oblique phenotype, the intermediate, and the vertical phenotype. And what you'll see with these patients is it's a function of a couple of things. One, how much AP bony distance do they have? So how far back is that maxilla set? And also the length of the soft tissue of the palate as well. So in the oblique patient, they have a nice AP distance there at the maxilla, leading to a shorter segment of soft palate that's actually obstructing with the posterior pharyngeal wall. In the vertical patient, you'll notice that there's a pretty long segment of soft palate that's contacting the posterior pharyngeal wall. So the patient with the oblique palate is the one that's going to do pretty nicely with a palatal operation, even the ESP, or a version of the expansion pharyngoplasty. And just going back here, honestly, either one of these patients would probably do pretty well with an expansion, because that patient on the top, I would say, has a pretty nicely oblique palate. You know, we're looking at a pretty long horizontal segment of their soft palate, not much of a vertical segment of that soft palate. So with this paradigm shift to more of these anatomy-directed reconstructive techniques, we think that we are improving effectiveness and decreasing morbidity for patients. So this was also a paper of Dr. Woodson's, where he looked at his traditional UP3 patients versus the ones that he had moved to using the expansion pharyngoplasty on. And largely, he was able to achieve higher success rates with the expansion pharyngoplasty version, closer to 80% versus that 40 to 50% range. Those are older papers, so I just wanted to mention a couple of newer reviews of UP3. So in 2018, there was a systematic review of the traditional UP3 as monotherapy, and even in more recent papers, it's still very clear that there are wildly variable success rates with this surgery. There was also a systematic review of long-term efficacy of palate surgery, which I think is important to be aware of. Many patients achieve success on the short term, so within the first few years after surgery. But as you get more towards the long term, so 5, 6, 7, 10 years, there's some return of events, some return of symptoms. So I think this is an important thing to be aware of when you're counseling patients. There is remodeling of that tissue, there is creep of that tissue, and they may have a return of symptoms in the future. Something else that I just want to bring up is that tonsillectomy works if the tonsils are big. That's probably where a lot of that Friedman staging success comes from, is the patients with big tonsils do well when you take them out. So this is just something that really wasn't studied until fairly recently. At Henry Ford, they looked at their tonsillectomy patients and determined that in those with 3 to 4 plus tonsils, so those tonsils that are quite large and often even almost touching in the midline, about 80% of those patients were able to do well with surgery with reasonable AHI reduction. This is also something I think is a reasonable thing to consider as an adjunct. So you have a patient with terribly severe sleep apnea. They're requiring really high positive airway pressures. Perhaps you can get some of this tissue out of the way. It's not functional tissue, so you don't necessarily have to worry about what's going to happen to those muscular structures, but you may be able to achieve similar AHI reduction with lower pressures with the tonsils out. I wanted to throw in a slide on other pharyngeal surgeries. So we know that most soft tissue surgery is done at the level of the palate, but there are several other procedures that can be considered. So at the base of the tongue, there are multiple things that are done. Lingual tonsillectomy, I think in the case of large lingual tonsils, is something that's very reasonable to consider, again, because that is not functional muscular tissue and you can get some bulk out of the way. On the left side here, you see a patient where you're looking down at their supraglottis and their base of the tongue is at the bottom side of that picture. Those are bulky lingual tonsils. So just like we think of our tonsils at the back of our throat, there's similar tissue at the back of the tongue. And sometimes that can stay quite hypertrophic into adulthood. The muscular base of tongue can be reduced. I think largely hypoglossal neurostimulation is replacing a lot of these robotic and otherwise muscular base of tongue reductions, as the literature is favoring neurostimulation over muscular reduction, but it's still done. Radiofrequency ablation of the tongue base is something that has been also shown in a randomized fashion to work for obstructive sleep apnea. Many of these other procedures are supported really only by case series. The hyoid suspension is a procedure that basically takes this hyoid bone and attaches it via suture material, usually to the mandible. The thought there is that this can pull the patient open at the level of the tongue base and possibly also the epiglottis. Some people will also pexy the hyoid bone to the thyroid cartilage to try to tense that area open as well. And then as far as the epiglottis goes, this is not common, but you can see every so often primary collapse of the epiglottis. Sometimes this is coupled to things that are going on at the proximal airway. For this patient, it's possible that the palate obstruction is actually what's leading to the epiglottic obstruction. So most people would still work in a proximal to distal fashion, but you do find some patients that simply have primary collapse of their epiglottis, and making that epiglottis a little bit shorter, a little bit stiffer, and pexying it to the base of the tongue may help at that level. A couple of things to mention here on multi-level surgery. So people will talk about, okay, well, if you can do the palate, do the tongue base, why not just do them both and open them up at multiple levels? There was a 2019 meta-analysis done of these single stage palate plus tongue base procedures. And they showed that overall, they did seem to work. The mean decrease in AHI was about 23. Something that I thought was interesting again is, even using different tongue-based procedures such as hyoid suspension, radiofrequency reduction, lingual tonsillectomy, the success rates were significantly different depending on whether or not the patients had their tonsils removed as part of the procedure. So those who had tonsils that still needed to come out generally did better when they had these multi-level procedures. And then I had to throw a bone to the paper that was recently published in JAMA, because we don't see sleep surgery literature making it into those sorts of journals very often. But there was a randomized trial done recently in Australia looking at multi-level surgery versus medical management and how these patients did. So this was a group of just over 100 patients that were randomized to one of two arms. The first was multi-level surgery, which consisted of an expansion pharyngoplasty variant as well as radiofrequency reduction of the tongue base. The other arm, medical management, basically entailed getting the patients back on CPAP or an oral appliance if they were willing, or coaching them through positional therapy, weight loss, and things like alcohol reduction. And what they showed is at 6 months, the patients that entered the surgical arm had lower Epworth scores and lower AHI. They did have requirements that the patients have at least moderate sleep apnea, and the BMI in this study had to be less than 38. It also should be noted, in Australia, they do not actually have access to the hypoglossal neurostimulator the way we do. And so they are often needing to do multi-level surgical options on these patients that may otherwise have had the opportunity here to have something like a neurostimulator. Bucket 3, bony surgery. It works. It is the general consensus. It's a big surgery to do, but it generally works. So the MMA is the one we think about most, the maxillomandibular advancement, breaking the upper and lower jaw, moving it forward. It does seem to work even in cases of severe obstructive sleep apnea. There's literature suggesting that at like the 10-year mark, we actually may see return of symptoms even in MMA patients, probably due to the creep that those soft tissue structures experience down the road. There are other things that can be done, such as rapid maxillary expansion. This is an example here in an adult patient where they have a palatal expander placed with surgical assistance to expand that palate. Who are we thinking of bony surgery on? So I think it makes sense to pay attention to some of these exam findings as well. I will admit I'm often distracted by soft tissue structures, but I think it's really important to pay attention to the patient's bite and upper and lower jaw structures. So some people you can tell outwardly they have a flattened maxilla, they have a retrognathic jaw, they have a very high and narrow hard palate. Something I like looking at endoscopically is the distance between the posterior septum and the posterior pharyngeal wall. And then I've learned a lot from our OMFS and orthodontic and dental colleagues regarding bite findings. So we talk about angles class. That's the relationship of the molars and the AP dimension, looking at significant overbite and overjet. There's also something to pay attention to is a crossbite. So if a patient has a crossbite, that's a sign of maxillomandibular disharmony and usually a small maxilla. So this patient picture on the top here, this is a patient with a crossbite. Occasionally you'll see the finding on the patient's right side where the mandibular teeth actually sit outside the maxillary teeth. This can even happen on both sides, and that's something that's referred to as inverted occlusion. Thank you, Dr. Pinto, for giving me that bit of info. And then sometimes you'll see that the entire tooth actually sits outside of the the mandibular molar sits outside the maxillary molar, and that's actually referred to as a scissor bite. So in patients that have dramatic findings like that with their bite and their jaw structure, I think it's extremely reasonable to consider these bony surgeries and our involvement of our craniofacial or maxillofacial colleagues. Lastly, hypoglossal neurostim is bucket number 4. This is something we've talked about a lot, but it's basically a device. The current FDA approved device is the Inspire device. There are others being developed, but the Inspire device is a 3-component system that includes a basically battery pack that sits in the right chest, a stimulator lead that goes around the hypoglossal nerve, and a pressure sensor lead that sits within the rib cage, usually on the right side. The patient then uses a remote to turn it on at night, and every time a breath is sensed, the tongue muscle structure is ideally moved forward. The most technically challenging piece of this operation is the getting the cuff around the right portion of the hypoglossal nerve. So our tongue muscle, our genioglossus muscle, is made up of multiple different muscle fragments that move the tongue in different directions. And the goal here is to stimulate the muscle fibers that are going to get the tongue moving forward and out of the way, and not the ones that are going to be pulling it back. And so we do have to do a good bit of nerve dissection and testing to try to get the cuff around the right part of the nerve. Benefits here, pretty much every patient can go home the same day. There's a very minimal narcotic requirement Compared to jaw surgery and throat surgery, the level of discomfort experienced after this surgery is typically significantly lower. And so potentially this is something that can be tolerated maybe in an older patient or a patient with some medical comorbidities that would not be able to go through some of these other surgeries. Another big benefit here is that it's titratable. It's not a one and done thing. You can, within reasonable limits, change the electrode configurations and the amount of stimulation delivered to try to tailor therapy. Some downsides to consider, especially maybe in a younger patient or a patient with a low arousal threshold, insomnia. Patient cannot get an MRI of their torso once this is in. The battery at this point, current version, has to be replaced every 7 to 10 years. So you're looking at multiple surgeries. And then lastly, something that I experience anecdotally are, patients who do struggle to fall asleep and may wake up very easily. This tongue motion can serve as something that stimulates them at night and can make it harder to fall asleep or stay asleep. The FDA indications currently, you have to have moderate to severe obstructive sleep apnea. So less than 25% of the total number of events can be central or mixed. Ideally, this is someone who has tried and struggled with and already failed some more conservative treatment measures. The body mass index in the pivotal STAR trial study was a cutoff of 32. So a lot of the literature that we discuss is in patients with a BMI of 32 or under. The current CMS, the Medicare Medicaid guidelines, require that patients have a BMI of 35 or less. And then lastly, we exclude patients who have what we call complete concentric collapse at the level of the velum on drug-induced sleep endoscopy. So this is looking at kind of that knee point of the palate. Are these patients mostly collapsing in a front to back direction here, or do they have a lot of lateral collapse as well, leading to that circumferential pattern you see on the right? That's a contraindication to this procedure. And that decision was based on a study of 21 patients where I believe there were either 12 and 8 or 16 and 5 where the smaller number did poorly with the procedure, and they were all found to have circumferential collapse. 12 and 8.
Looked at since then, yeah. Been looked at since then though, because some concentric collapse have slipped into the system. So there'll be a paper coming out of what it does, and some do well and some don't.
So there's a thought too, and Kingman, I don't know if this is something that was looked at in that study, is do these patients have what we call good palatal coupling? So potentially via that palatoglossus muscle, if when you pull the tongue forward, does the patient also pop open at the palatal level? And you'll find even in those with a lot of lateral wall collapse, every once in a while, you'll find a patient that you pull their tongue and their jaw forward and they do pop open pretty nicely and have that palatal coupling. So perhaps the coupling is the more important thing rather than just the presence of circumferential collapse. So our outcomes here. What are our outcomes with hypoglossal neurostimulation? So there's a couple of studies, the 5-year data from the STAR trial and the German post-market study that looked at treatment AHI, and I'll explain what that means. If you look at treatment AHI, the AHI response rate at 12 months and 5 months or 5 years respectively in these studies was about 75%. A similar proportion of patients do better with their sleep-related quality of life and their sleepiness. It is important in the literature to pay attention to the outcome measures that are used in these papers. A lot of papers will report a titration AHI, which, similar to our CPAP titrations, basically just reports the AHI seen at that level on the titration study. So it'd be like looking at your CPAP titration, in the 15 minutes they spent at a CPAP of 17, their AHI was reduced to 3. So that's similar what you're looking at here with this neurostimulation. The titration AHI is going to be saying, okay, at a voltage of 3.4 volts, they spent X number of minutes here and had an AHI here. What you really want to look at is a treatment AHI, and that's full night data, ideally with PSG, but also with HST. There's also a push here to use the ODI-4 as an outcome measure in these studies, because AHI is this moving target, lab to lab, home test versus in-lab test. Looking at the ODI-4 may serve to compare apples to apples when you're looking at pre and post-operative AHI, and also lab to lab, health center to health center. The ADHERE registry is a registry that it's aiming to have upwards of 5,000 patients in it for hypoglossal neurostim. And so we've gotten some more data out of that registry since the STAR trial data was published. What we've learned is that older patients do better than younger patients. Success rates increase by 4% for each year of age. Women may also do better than men. This didn't reach statistical significance, but it did show that trend. BMI, in terms of BMI, it does seem that for each point of BMI increase, our success rates do go down. There's some literature that states that there's no difference in success rates in those with a BMI of 32 and above versus 32 and below. But if you kind of break that paper down, these are the groups they had. So the group with a BMI of under 32 had a mean BMI of 27 with a standard deviation of about 2. And above 32 was a BMI of 34 with a similar standard deviation. So, you know, they're not straying from that BMI requirement too wildly. I would say most people are still considering this in those with that kind of mid-30s BMI range and below. There's also a thought that the elevated BMI may lead to this circumferential collapse. There are lateral fat pads in the pharynx, and that might be part of what we are seeing collapsing laterally. There's a paper, I know I have like 2 more slides, so I'm almost done. Paper in JCSM in 2019. Those with lower CPAP requirements may also do better with hypoglossal neurostimulation. This may be kind of an indirect measure of our P-crit. Those with lower P-crits may do better with Inspire. Similar things have also been shown in the oral appliance literature. And then lastly, this is something that I looked at with Dr. Stroll and our research fellow recently. We looked at REM and non-REM predominance of the sleep disordered breathing burden as a surrogate measure for potentially anatomic versus non-anatomic underpinnings of sleep apnea. So we know that loop gain and arousal threshold issues tend to be more prominent in non-REM sleep than in REM sleep. So the thought is, if the patient has non-REM predominant sleep apnea, could this be a surrogate measure of non-anatomic pathology? Something interesting we found is that almost 2/3 of the patients in the STAR trial, if you look, have non-REM predominant disease. My thought there is these are patients that were struggling with CPAP, potentially due to these other physiologic factors. Maybe that's what kind of led them to explore this alternative option. Something else we found here is that the interaction with age and REM predominance, that interaction term, does seem to predict success in terms of AHI and ODI reduction. So those with REM predominant disease seem to do better. And as age increases, this effect size also increases. It would be really great to look at this in some other surgeries as well. You know, we need pre-PSG data to be able to look at this, and the STAR database was an excellent place to do that. But I hypothesize that this is not just a neurostim thing, and potentially also we would see this in other surgeries as well. So in summary, just important to figure out what we are treating so that you can have a good risk-benefit discussion with the patient. What kind of physiology are we treating here? Are we truly treating a narrow airway? Or are we treating someone's low arousal threshold? And then as we think about how we treat, both surgically and non-surgically, there are a lot of factors to consider. There is going to be no one BMI that's going to make a patient a good surgical candidate or not a good surgical candidate. We've got to think about their airway anatomy, their overall body habitus, and other things about their health. How old are they? How sick are they? What underlying physiology do they have for their sleep apnea? And lastly, we're hearing a lot about social determinants of health. That matters a lot here. You know, what is their perception, their bed partner's perception of what's going on? You know, do they have access to a clinic? You know, for Inspire, we have so many post-operative visits, and so you're going to need a relatively health literate patient who's mobile and can get to a clinic with a programmer. Do they have electricity? Can they plug a CPAP machine into a wall? So these are all things to think about for these patients. Lastly, my most important slide. This is the redhead that has pretty much taken over my life. I just wanted to say thank you to everyone who supported me while I was out helping with patients and orders and sleep studies. I really appreciate it. And this is Emily. She's now almost 4 months old.
You want to be a surgeon, Emily?
I was told she has surgeon's hands.
Wow, really?
I think it's a little early to tell.
I did too when I was a baby.
So I'm happy to try to answer any questions. Sorry, that actually went a little longer than I thought. But,
Hi, Amy.
yeah.
Welcome back. And I just wanted a comment on the buckets concept. I really like that because sometimes we're thinking about conceptually whether we send to ENT or not, and it's very helpful to have those sort of buckets to think about. Welcome back.
Hi, Amy, this is Dennis Ockley. I have a quick comment and a question for you. That's great talk. It was kind of interesting the way when you kicked it off with the paper about sleep docs not really embracing ENT surgery. And I'm going to call that the Barb Phillips effect, which maybe Kingman will recall. She was a prominent sleep doc that it would get up at all the ASM meetings and for years just pound on the podium and there's no role for ENT surgery. And so she really ingrained it in a lot of folks. And to her defense, the last guideline from the ASM was in 2010, and then they only looked at a small number of surgeries and really did not come out in favor of that. And I'm hoping that with the randomized controlled data that's come out with the Inspire, that'll spur better and higher quality literature from the ENT side related to the surgeries. But the question I had for you is, what do you think about doing sort of stage procedures to try and get patients to an endpoint, whether it's to resolve the sleep apnea or to make them a candidate for like the hypoglossal nerve surgery? So like doing a expansion sphincteroplasty to change a lateral collapsing or concentric collapsing airway to an AP or something like that. Do you have thoughts on that?
Yeah, I mean, I guess I'm of the camp that I prefer stage surgery over doing simultaneous multi-level surgery because I think, physics would suggest that any alteration of upstream anatomy can affect the downstream anatomy. Also, just anecdotally, patients who are getting multi-level pharyngeal procedures and nasal procedures simultaneously are miserable and potentially at higher risk for getting those procedures. So I think that especially in certain candidates. So if you have a younger patient who can tolerate that palatal procedure and potentially has some reasonable hope that they might even improve simply with that procedure, I'd say absolutely do that first. And then you can consider after the fact, how are you going to, if they still do have an elevated AHI and collapse at the tongue base or hypopharynx, how are you going to address that? Whether it be with an oral appliance, positional therapy, lingual tonsillectomy, or hypoglossal neurostimulation. I think that the literature on stage procedures, unfortunately, is pretty sparse. And so that's up to the sleep surgery community to publish on it. But in a patient who can tolerate those procedures, I'm absolutely in favor, say, start with the nose, try to get them back on CPAP. If that doesn't work, move to the palate. If that doesn't work, move to the hypopharynx.
Great, thanks. And daughter's beautiful.
Good looking kid.
Don't know where she got her red hair.
I know. Well, from the Vikings, of course, right? It's a Neanderthal trait. Good.